Might get started. Last station on the Airway workshop. Just get you all down this end to start with. My name's Nicholas Chrimes. I'm an anaesthetist. I'll just introduce my co-conspirators here. Todd Schlesinger from Long Island, New York, is an emergency physician. Liu Cong, who I'm sure many of you are familiar with, ED physician and retrieval physician. And Anthony Lewis is an anaesthetist from Sydney. We want this to be an interactive session. This is not about us just telling you what we think. This is about having an opportunity for all of you to share your own experience and tips about having the best attempt to optimise the three non-surgical airway techniques: face mask, supraglottic airway and endotracheal intubation. What we're bringing to the party is a template, a framework to put all these interventions you might do in so that you can implement them efficiently and effectively in a crisis. So we're going to frame this all around the Vortex Approach. So for those of you who aren't familiar with the Vortex Approach, the premise is this: there are only three ways to get an airway non-surgically: face mask ventilation, supraglottic airway, or endotracheal intubation. If your best attempt at any of these fails, you need to spiral into this funnel. This is sort of looking down into a funnel from above, and have your best attempt to the next one. If your best attempt at all three fails, you spiral down to emergency surgical airway. If, on the other hand, you're successful with any of these three attempts, be it intubation that you wanted in the first place or one of your rescue strategies, you instead of spiralling into the middle of the vortex, you move outwards into what we call the green zone. The green zone is any time that you can confirm that alveolar oxygen delivery is taking place. For most situations, that means getting an end-tidal CO2 trace back, or in a situation where the SATs have already fallen, seeing the SATs come back up. Those two things tell you that you are supplying oxygen to the alveoli. What doesn't tell you that you're supplying oxygen to the alveoli is seeing previously high SATs from pre-oxygenation staying high. That tells you that you were supplying oxygen to the alveoli. In fact, the whole point of pre-oxygenation is to allow the SATs to stay high despite you being unable to supply oxygen to the alveoli. Now, whilst the right side of this gets a lot of attention because it's pretty, what we're going to deal with today is the left side. It's very easy for me to say, let's have an optimal attempt at each of the three non-surgical techniques. The question is, how do I make sure I can do that in a crisis? I'm sure all of you have techniques that you would like to implement in that situation where you're struggling with any of those three non-surgical airway techniques. What we see time and again in real life crises and simulated crises is that people fail to do stuff, simple stuff. They know to do it, they know that it needs to be done, they know how to do it, they just forget to do it. So what we have here on the left is a series of 5 general categories of optimisation manoeuvre. Manipulations, adjuncts, changing the size and type of something, suction or oxygen flow, and muscle tone. Pretty much everything you can think of to optimise non-surgical airway techniques, to optimise all of them, can be put under those 5 headings. So for example, if I take adjuncts for face mask ventilation might be a Guedel or a nasopharyngeal airway. Adjuncts for endotracheal intubation might be a Bougie or a Stellette. Adjuncts for putting a laryngeal mask in might be using the introducer on a ProSeal, might be using a laryngoscope to help you place the laryngeal mask. That heading works across all 3 techniques, as do all the headings, which means if you're in a crisis, you're struggling with one of the non-surgical techniques, people can say, do you want to try some manipulations? Do you want to try some adjuncts? If you've sort of categorised the things you do to optimise the attempts under those headings, that allows you to rapidly say, actually, that's a great idea. No, that's not going to help me in this situation, or I've already done that, hasn't worked. Okay? So the idea is that these categories help you be prompted to have an optimal attempt in an efficient way. Now, there are other things you can do to optimise things like face mask ventilation that don't fit into those, things like shaving off the beard of a bikie. They're not included there because they're not things you can do in real time as the do SATs are falling. Their vortex optimisation strategies are directed at making sure that the things you can implement in real time in a crisis you're able to access quickly. Okay? That doesn't mean that should be the first time you think of doing them. Ideally, you should be looking at this and using the Vortex also to plan, to think about, how do I have my best attempt at face mask? How do I have my best attempt at supraglottic? And what optimization strategies are I going to implement? And make sure as many of those are put in place before you induce the patient, and that the others are planned out and the equipment to intervene and do them is immediately available. Okay? One of the things, so planning doesn't start just in the 10 minutes before you induce the patient. Planning starts now. Part of this workshop is you planning airway management, making sure you've thought about how am I going to rapidly access the skills to optimise my non-surgical airway techniques, how am I going to make sure I have that I'm aware of all the possible interventions that I can do. And also, as you go around, you'll probably see some bits of equipment that you don't have in your clinical environment. Now, that doesn't mean switch off, I don't have this, this isn't relevant to me. That means, let me have a look at this, because if this really is a game changer, maybe I need to think about a way to get some funding to get this in my environment. And that's part of your long-term planning for not just setting it up for that patient, but setting up your whole department so that you can optimally manage airways. One of the things we talk about when we're doing the optimising endotracheal intubation is changing the size or type of the laryngoscope. So I'm a fierce advocate that in most situations the Mach3 does the job. Min is a big advocate of the Mach4. Now the Mach4 argument, as many of you may be aware of, goes like this. It has a Mach3 in it already. That means if I don't need the length, I don't use the length, but if it's too short, I can put it all the way in and I don't have to instrument the airway again. Sounds like unassailable logic. As a registrar, I thought that sounds good. I like that. That's what I'm going to do. Except it didn't work. When I went to a Mach3, I always had a better view. And this is why I think it is. Imagine that the laryngoscope is 6 feet long. How hard would it be to resist pressure on the tip of it? The further away the tip gets from the handle, the harder it is for you to resist a downward force at the end of the blade. Now, I'm not suggesting that you're trying to do this during laryngoscopy, but in holding your blade horizontally, you're trying to resist the downward rotational force of the tissues on the end of the blade. In a big fat patient, it may be harder with a Mach4 to lift than it is with a Mach3. Can I have a volunteer from the audience?
Thank you.
Just someone at random. Can I confirm, Dr. Liu Cong, that you are in fact right-handed?
I am right-handed.
I will give you your favourite, the Mach4, in your dominant hand, with which you will have the mechanical advantage.
Let's do this, come on.
In the other hand, the Mach3, I'm also right-handed.
Yes, you are.
Min's dominant hand against my non-dominant. All I want you to do is hold it steady, resist me pushing down.
Right. Okay, let's try it this way.
What the hell is that? What are you, a Terminator now? Transformer. The point is there is a substantial, just with that little bit of extra length on the blade, there's a substantial mechanical disadvantage with the Mach4. Now, I'm not suggesting that intubation is all about brute force, but there will be situations where you've done everything right and your technique is right, that just getting that extra bit of lift makes a difference. And that's why I think I have a better look with the Mach3. At the end of the day, though, what you should do is what works for you. And what this workshop is working out what works for you. So we're going to split into 3 groups. We're going to have 6 or 7 people over here doing supraglottic airway with Min, 6 or 7 people here doing intubation with Todd and Anthony, and 6 or 7 down here with me doing face mask.